EpiSurveyor arose from my initial work with CDC when we used to go out, I used to go out and do outbreak investigations. And, you know, it's actually interesting speaking to a group like this about sort of information and the sources of information, because I find many times now when I'm talking to people, not this group, but when I'm talking to people, they think that all information is available from Google. And I have to try to explain to them that many times I'm the guy who puts the information on Google. Actually, like with maps, the previous speaker does, right? Who actually puts it there. And in public health, if you want to know something, if you want to know information like what percentage of women in Botswana are HIV positive, you cannot Google that information, at least not to get anything up to date. You have to go measure it. You have to go house to house, or you have to go to a clinic. You have to do a sample. You have to knock on doors, write down people's names, draw blood, do the test, compute the statistics of it, determine the probabilities or the percentages of the population that are HIV positive, et cetera, et cetera. You have to do a lot of shoe leather epidemiology, as they call it, at CDC. And I was astonished when I went to work at CDC back in the mid-90s, I was astonished to find that all of that was done on paper. Even though at that time, that was a time when Palm Pilots and those kind of handheld computers, not yet cell phones, but unconnected pocket computers, began to be available. I was amazed. And I thought, this isn't a question of not having enough money. I mean, I'm not talking about the Ministry of Health of, Zimbabwe. I'm talking about the US Centers for Disease Control. They had all kinds of money to do all kinds of stuff. And yet, they were using paper to do that. And although we've made a lot of progress, which I'll tell you about, I'm dismayed to report that my estimate would be that about 95% of public health information in developing countries is still collected on paper, which is something that we're trying to change. And what are the effects of collecting that data on paper? What are the effects of not using the pocket computers, which at that time we would have had to buy for people, but my point is that now those people are carrying those pocket computers around with them right now, so we don't even have the excuse of not having the money to buy the hardware. But what are the effects of that? Well, I'll tell you, I would say in a routine sense, we've been heavily involved with measles vaccination. I don't know if anybody has read anything about that in the last couple of years, but there's a tremendous push to vaccinate every kid against measles. Why? In the United States, nobody ever dies, even when there's a very rare measles outbreak, usually introduced by someone who's visiting the country. But nobody ever dies because kids here are well-nourished, and it's only the malnourished, typically, and the vitamin A deficient that die when they get measles. But in Africa and Southeast Asia and South America, kids die all the time of measles. So there's this tremendous effort to do measles vaccination. And part of the reason for the success of this effort, which is ahead of time and under budget for vaccinating hundreds of kids, or rather millions of kids, pardon me. Why is it ahead of time and under budget? Lots of different reasons, one of them being that it uses modern information technology to do its surveys. Before we worked with them to use handheld computers, PDAs, to do their field surveys. See, after they do a vaccination campaign, they might go to Zambia, vaccinate 1 million kids in the space of 2 weeks. Then the question is, how do you know how many kids you vaccinated? They used to use a system where they knew how many doses they had beforehand, and they counted up how many doses they had left. And they said, well, we had 1 million doses, and now we've got 100,000, so we must have vaccinated 900,000 kids. But of course, the problem with that is that you essentially had the people who were doing the vaccination also doing that counting. Therefore, the people who were doing the vaccination were essentially evaluating their own performance. And so, of course, there were incentives for people to overestimate the number of kids that they vaccinated, and that doesn't do anybody any good. So they began doing these household surveys done weeks to months after the vaccination campaigns, where they go house to house in a huge sample of households throughout the most rural parts of these countries. They try to cover all over the countries. They collect information. Do you have any kids? Were the kids vaccinated, et cetera, et cetera. And when they collected this stuff on paper, I'm not making this up, it would usually take, let's say, anywhere between 6 months or a year to get that information from paper into a computer to analyze it. Right. Now, imagine trying to run any kind of an organization or manage any kind of a process where the best information you have is a year or 2 or 3 years old. You just can't get any. Can you imagine the president of Toyota asking for sales figures and being told, well, we're not actually sure how much we're selling, but we did sample one dealership in North America, and that seems to be going pretty well, although we sampled it back in 2005, so we're extrapolating, and yet that is the kind of quality of data that is often used to make these tremendously important, to run these tremendously important public health campaigns. Now when they do these surveys, because of this software that we've developed to use first PDAs, unconnected pocket computers, and now to use mobile phones to do this data collection, now there is no lag between the performance of the survey and knowing the answer to the question. And in fact, there's no lag between the performance of the survey and having the data posted someplace where everybody can actually look at it, not just the people who were involved in it. So there's even greater transparency and standardization. So again, initially this was PDA based, but then miraculously, through no fault of our own, no intervention of our own, over the course of the time when we were developing this, happily, people began buying these mobile phones. Again, back when we started this project, I didn't have a mobile phone. Now, the last time I went to Kenya for our project, I brought 2 iPhones for colleagues there who asked me to buy them so they could pay me back when I got there. So people are adopting even high-end phones at a very, very high rate. And this shows one of our health workers in Zambia who is out in the field with a PDA, not yet a cell phone. If she was doing it now, she'd be doing it with a cell phone, using a PDA to collect information about that mother and about her child that was vaccinated. Again, eliminating literally years of delay in data using just the simplest possible computing tools. And the good thing about EpiSurveyor, or the reason why EpiSurveyor, we hold this out as an example not only of giving something to the people of Africa to use for public health, but actually of teaching them, of giving them a capacity to do it, is that EpiSurveyor, the software, is both open source, it's free, so if developers want to muck around with it, that's fine. But EpiSurveyor is not handing someone a PDA that has, or a cell phone that has a single survey on it. It is a survey creation system, a form design system. So you give them software and train them in software that allows them not just to do the measles vaccination survey, right, which is how it was initially done when people started computerizing this stuff. It gives them software, it lets them program the measles vaccination survey, but then it allows them to program any survey that they want at a level of difficulty that's comparable to something like Microsoft Word. Anybody who can use Microsoft Word can use this software. And so what it enables them to do is, you can just see a few examples here. These are recently produced reports coming out of Kenya for outbreaks of disease, including cholera, I think is the example in the front, in refugee camps along the border between Kenya and Somalia, where people have basically been sort of pouring in because of the troubles in Somalia. There's some terrible conditions up there. They're trying to follow it up. Prior to us developing this very simple software to be used on mobile devices, if they wanted to do this kind of a thing, if they wanted to get that information so quickly and not have to do the data entry, they would have had to pay some consultant. They would have had to get an international consultant to come program the questions. I mean, think about that. You're an expert, you're a local expert in Kenya on cholera. You know exactly what 30 questions you want to ask. But if you wanted to ask them on a mobile device and save all that time and have better quality data, you would have had to hire me and pay me $30,000 to come and program those questions into your cell phone. I mean, think about that. Think about the kind of barrier that provides to even the collection of data, right? I mean, we're talking not only about giving people access to the technology, but the ability to manipulate and create with that technology themselves. Because the fact is, if I had to hire a programmer or speak to a consultant every time I wanted to send an email, how much email would I send? Right? If every time you wanted to do a web search, you had to talk to a consultant or bring the IT department in, how much would you do? Right? It represents a real barrier to the use of this. And so what we're trying to do now, again, with the cell phones, is not only create interesting tools people can use on cell phones, but tools that in every case they can manipulate and change and create with themselves. Some of the things we're working in besides this are, as I said, a cell phone and a PDA-based medical record system, so that physicians in rural areas, or typically it's not a physician, typically it's maybe a high school educated health worker, or maybe it's a nursing assistant, who invariably, I can tell you, every single one of them has a cell phone, and we're working on a system to enable them to use that cell phone to keep track of all their patients. And of course, because it's a cell phone, it's connected, then as they collect information with all their patient information in the cell phone, it can be automatically synchronized with a database at the national level or the provincial level. So without any additional work for that person, you've made their life easier, and you've given the people at the central level the ability to keep better tabs on what is going on in the country, to predict what kind of supplies they need, to understand when outbreaks are arising, etc. All this is done with a cell phone via an SMS interface, via a text interface. Very, very simple stuff.